just want to say a few words. She joined MBBS as a 1963 batch in Kilpak Medical College, and she finished in first class. And she joined DGO in Madurai Medical College, and she joined service in 1969. First at Government Pentland Hospital, Vellore. She did many good things in her service. She joined in Volaja GH when it was a Taluk Hospital and worked between 1985 to 1995. For 10 years, she did many family planning surgeries. Operation theatre was functioning that time, but she renovated everything and she uplifted all the services in Volaja GH as a chief medical officer. And one more thing, she has done a tremendous job. Everyone know about the location of the casualty and Simong building in Volaja GH. That was a market and open place for the past 30 years. When she was the chief medical officer in Volaja GH, she encroached and she talked about the government and she captured that land from the market, from the general public market to Volaja GH. So in that place, we have many services right now, like COVID building and casualty, trauma care center and Simong building. Now newborn care unit, everything. So we are very grateful to her. For her achievement. She has two kids, one male and one female. Our son has done. He's a general surgeon and he's working in states. He's married. And daughter Priya, she's a dermatologist and a senior consultant in Apollo Hospital, Chennai. Recently, madam has got some injury, foot fracture, so she's not able to properly communicate to us. She did many achievements in Volaja GH. Then she was transferred to Government Pentland Hospital, Vellore, and where she worked for a few days, and she went on voluntary retirement service. Since even though she left our hospital and retired from service, her achievements and her grateful things to our hospital still alive. Now she is around 75 to 78 years old, but she still she talks to me and asks about how Volaja is going, how it is working, and how people are getting benefited like that. So we are missing madam in this CME. We all wish her for a healthy and prosperous life. Then I request all the doctors in this forum to get vaccinated for against COVID virus, because we are expecting a second wave. Please, many of the doctors in our IMA branch are not yet vaccinated. Please, both Covishield and Covaxin are available in Volaja GH. Please do get vaccinated and please benefit it, because there are more chances for second wave in our state. So I request all to please follow this. Once again, I wish all the doctors International Women's Day. One more thing, in this 2021, the theme is Women in Leadership. So, for example, our IMA president is a woman. So that itself implies our theme. And our guest of honor, madam, is also a woman. Then our DSP madam is also a woman. And our previous district collector, the first district collector of our district is a woman. So everything standing in a place for women being a good leader in our town and state. So I once again thank our president madam and secretary sir and treasurer sir for giving me this opportunity to talk about a great legend of Volaja GH. Thank you all.
Thank you, Dr. Venkateshwaran. A great legend indeed. Actually, we didn't know much of this. We know only that she's a senior most person. Probably the 63 batch of KMC was KMC started only around 60, I think. So one of the first batches. Very nice to hear, and of a great work in Volaja GH. And thank you so much for taking all the effort to find all details about her and to tell us. Thank you very much, Dr. Venkateshwaran. Thank you. And thank you for the nice words for all the women of the group. Thank you. Now we move on to our CME, and we are very grateful to Apollo Cancer Hospital, Chennai, for hosting this program at a very short notice. I thank them again. I welcome Dr. Rajesh Balasubramaniam, who's a consultant breast surgeon, Apollo Cancer Center, Chennai. He will talk to us about benign breast disease, symptoms, and management. Welcome, sir, and thank you for accepting our invitation at a short notice. You're here, sir? Hello? Dr. Rajesh, sir, you're there.
Can you hear me?
Yes, sir. Yes, sir. Welcome, sir. Welcome. And let me introduce him to you, Dr. Rajesh Balasubramaniam. He has completed his UG from Stanley Medical College in 1995, and then he did his general surgery in Madras Medical College and completed it in 1999. Then he had further general, laparoscopic, and breast surgery training in UK, and he also did his research in breast cancer at Imperial College London. He also did his research in breast cancer and he finally completed his fellowship in oncoplastic breast surgery at Guy's Hospital UK. And now he is a consultant breast surgeon at Apollo Cancer Center, Chennai for the past 2 years. So over to you, sir, for your topic.
May I be excused, ma'am?
Thank you.
Sir, madam.
May
Please,
I be
madam.
excused?
Yes, madam. Yes, madam. Thank you so much, madam.
Thank you so much, everyone. It's a pleasure meeting all of you. We'll meet sometime in person. Thank you.
Yes, ma'am. Thank you so much, ma'am. Thank you.
Okay, thank you, Dr. Geeta. Thank you for your kind introduction. Am I audible?
Yes, sir. Yes, sir.
Okay, and can you see my screen also?
Yes, sir. We can see.
Okay, thank you. I'm extremely conscious of time, so if I go beyond 15 minutes, please feel free to stop me. I don't want to bore you at this late evening. Okay, I chose this topic, benign breast diseases, because it's much more common we come across than the breast cancers. So I thought it would be prudent to discuss about benign breast diseases. So the common breast symptoms, as we all come across, is breast pain, or patient can present with breast lump. Sometimes they present with nipple discharges and infections. So if we talk about breast pain can be related to breast or it can be related to chest wall. So let's go through one by one. Breast pain, which is breast related, or commonly pre-menopause. It's cyclical, can be unilateral or bilateral, and it is hormonal most often. So that's why it comes in the pre-menopause age group. Rarely it can be related to chest wall also, but usually it is hormonal. So if you examine, you won't find any findings except some tenderness, probably mild to severe. Whereas if you take the chest wall pain, it's usually common post-menopause, and it's usually worse on movement or history, and it's tender to touch, especially the costochondral junctions. How do we manage breast pain? The important thing is to reassure the patient. In young patients, the history itself will suggest it's hormonal. And if it is indicated, we can do a mammogram. Mammogram, all these investigations are, we need to remember, is not to diagnose the cause of the pain, it's rather to rule out any other accompanying or associated lumps or any other problem. So it is not to diagnose, rather to rule out. So once it is normal, then we can reassure the patient. But we have to be mindful, ultrasound is not a screening technique, meaning if a patient says a specific pain in a specific area, ultrasound is quite nice to see if there is any lump. But as a screening procedure, just to look at the breast using an ultrasound and say that it is normal, it doesn't mean that we have ruled out everything. In other words, it is a combination of history, examination, and the investigation should suggest that whether it is something to worry about. As a rule of thumb, pain is not a sign of cancer, because that is what the patient is looking for here. So reassurance is the most important thing, wearing a well-fitting bra, because that is the most important part of pain management, which we don't normally advise the patient, and the patient is also not aware of that. Rarely medications are required. Sometimes evening primrose oil is prescribed. There is no clear evidence to say that it is helpful, but the patient always feels better when we prescribe something, and evening primrose oil is not a bad choice. So if we go to the lumps, the common lumps are fibroadenomas, cysts, and I put infections in the same group as lumps. And some of the conditions are not malignant, but they are pre-malignant. They are called conditions of unknown malignant potential. And I'm not going to discuss about this today. I'm just going to discuss the rest of it. fibroadenoma is the most common lump we come across. It's usually common in the age group of 20s. But many times these lumps are picked up in 30s and 40s because that is the first time they do mammogram or ultrasound and suddenly a lump comes up. Usually the fibroadenoma is a lump of 20s age group. It can be single or multiple, and it's usually a painless lump. Sometimes patients do say that the lump is painful and tender to touch, but it is usually hormonal pain rather than the lump itself causing the pain. This is very important in terms of management, which I'll come to it later. Normally, it stays the same size, but sometimes fibroadenoma can increase in size in a minority of patients, especially in younger patients. So they need to be warned that sometimes this can increase in size. So ultrasound is the investigation of choice where it has a typical feature for a fibroadenoma. Biopsy confirms the diagnosis. Should we do biopsy for every single patient? My practice is any lump above the age of 25, I do a biopsy. Especially any lumps, even if it is reported as fibroadenoma in the age group of 40 and 50, and if that is the first time the lump was picked up, I would suggest a biopsy because fibroadenoma, first of all, we don't have any confirmation that this lump has existed for a long time. Second, in 40s age group, as I said earlier, fibroadenomas are not common. So it is safer to do a biopsy unless it is a clearly diagnostic in ultrasound where they say it's a calcified, hyalinized fibroadenoma. So the radiologist, it's better to discuss with radiologists to say how confident they are to say it is a fibroadenoma before we dismiss this as a fibroadenoma. So what is the treatment for fibroadenoma? No need for removal if it is confirmed. That is precisely the reason why I do a biopsy. I do the biopsy, confirm it, reassure the patient. We don't need to remove it. It will not turn into cancer. It's completely a benign lump. Surgery is indicated only if it is getting bigger or if it is from the diagnosis, the size is quite large or it is unsightly, cosmetic, for cosmetic reasons, or if the patient wishes. But the important thing is to inform the patient that it is a benign lump and they can make the choice whether they need a lump removal or not. Because especially if they have multiple fibroadenomas, we can't be doing too many scars on their breast. Most important things, as I mentioned earlier, don't remove for relief of pain because the pain will persist even after removal of the lump. Because the pain is not due to fibroadenoma, it is more of hormonal. So that's precisely what the patient should know. If the patient wants to get it removed, we have to convey that clearly. Cysts are again completely benign finding. It's common in perimenopausal age group and present in any age group. It is classified as simple and complex cyst. When you read the report, if it is a simple cyst, it clearly means it's benign. We don't need to do anything. We can just leave it alone. It tends to vary with periods and disappear after menopause. Sometimes it can be felt as a lump and found incidentally on imaging. When the report comes, the important thing is to read the report, see what it says, whether it's a simple cyst or a complex cyst. Ultrasound is the diagnostic procedure, the diagnostic investigation. So, as I said, simple cysts require no intervention. Reassurance is all that is required, and the patient can be reassured that this will, with time, disappear. Aspiration of fluid can be attempted if the patient complains of pain or if the cyst is large, more than a centimeter. Usually, sub-centimeter cysts are difficult to aspirate. Complex cysts are cysts which have, more than some septae inside, or there is a solid and cystic component. So these are all classified as complex cysts. Complex cysts are most of the time they are benign, but still they need to be aspirated or biopsied, especially if it's a combination of cyst and a solid component in the cyst, because this could mask the malignancy. So infections of the breast is again one of the commonest things we come across. They can be divided into lactational abscess or non-lactational abscess. Lactational abscess occurs common in the first 6 to 8 weeks of breastfeeding, follows a crack in the nipple and the infection process through the nipple. Starts as mastitis which means there is no pus. The patient usually complains of pain, redness, and almost like an abscess. If you do an ultrasound scan, there won't be any abscess. It's only mastitis. This is the time when the patient can be treated with antibiotics, good breast support, and sometimes applying warmth, and very local treatment is to apply jasmine, which is found to be quite good for the mastitis, but not for the abscess. So, especially we have to suspect abscess when it is when the patient is really unwell, like with fever. So, ultrasound will prove whether there is a pus inside or not. So, we have to treat it with antibiotics. The commonest offending organism is Staphylococcus. So, something which works against Staphylococcus is good. And aspiration of pus. If there is a pus, it needs to be aspirated with ultrasound guidance along with antibiotics. Sometimes a couple of aspiration may be required, and this pus sent for culture. The reason why we send for culture is sometimes the Staphylococcus is MRSA, it's methicillin resistant, so we may have to change antibiotics, but it is always a good practice to send for culture. Surgical drainage is almost out of vogue now. We rarely do surgical because it is an anesthesia. Patient can, it leaves an ugly scar, and recovery can be delayed, and even breastfeeding can be postponed because of these things, which is very important for women to breastfeed. So aspiration is required. There is a role for surgical drainage, especially when the skin is threatened or the abscess is multilocular. The surgeon would be able to make the distinction when to operate. But ideally, this should be aspirated. One of the other key questions women ask: can they breastfeed? Actually, they can breastfeed, but a lot of people are very anxious to breastfeed. So what the advice should be is they have to empty the breast, because the presence of milk in the breast causes more mastitis, more infection, and it also makes very uncomfortable for the patient. So feed in the other breast, and empty this breast, so that the recovery is earlier. Now, non-lactation abscess can be periductal mastitis or granulomatous mastitis. Periductal mastitis are usually uncommon here. We have not come across many in India. It's common in smokers, as you know, there are not much of smokers in India. It's due to the infection around the lactic ducts. The patient is non-lactating. Typically, the pus points or the inflammation and infection seen around the nipple, the areola skin junction. So when you aspirate, usually you don't see any organisms. They can be treated with antibiotics again. And aspiration of pus or the quit smoking if they smoke. Usually surgery should be avoided as this can be recurrent. The commoner one is the granulomatous mastitis. They typically present with lump or sometimes multiple abscess in the breast. Commonly it is idiopathic, meaning we can't find the reason for the abscess, but TB may have to be ruled out. And sometimes when they present with lump, they can mimic cancer. They typically appear as hard lumps, and in the mammogram they appear very irregular. When you do a biopsy, it proves it is actually granulomatous mastitis. So when we suspect, when they see a granuloma, it's always better to send for AFB culture, staining, gene experts to rule out tuberculosis. But a lot of the times they come as negative. So how do we manage this granulomatous mastitis? It is very difficult to manage. There is no one way of managing it, unfortunately. When there is a superficial infection with pus, again aspiration is needed with antibiotics. Once it settles down, if the TB is proven, we can treat it with TB. If there is not TB and the patient is asymptomatic, there are a few approaches we can take. One, we can observe the patient and see what happens. Usually self-limiting, but we need to reassure the patient that this can reoccur and manage the expectation. That is the most important thing here. Because every time patient comes to you, you always think, this will go away with antibiotics or one-off surgical drainage or aspiration. We need to explain to them if it is a granulomatous mastitis, this is a prolonged condition, can take even up to 7-8 months for it to heal completely. And unless there is a clear etiology like TB, it can be tricky to manage. There are reports where empirical ATT can help, or sometimes steroids also help. So it is a very difficult condition to manage. The most important thing is if it's acute, manage it with as an acute abscess, drainage, and antibiotics. Once it settles, we can give a period of antituberculous treatment or even steroids, which all help. The steroid should be given at least 6 to 8 weeks and tapered down. The most important thing is to avoid surgery again in these patients because they leave a non-healing ulcer, distorted breast, and really difficult to manage once surgery is attempted. The third is nipple discharge is again is common in perimenopausal women. Many of the discharges are expressed discharges rather than spontaneous discharge, and this can be unilateral or bilateral, little or high quantity. It can be anywhere between milky and greenish or bloody discharge. Discharge which is unilateral, spontaneous, bloody is likely to be pathological. Bilateral discharges coming on actually pressing the nipple or during the perimenopausal period. These are all usually a physiological discharge. This can be patient can be reassured after proper investigations. So even bloody discharge, 90% of the discharge is not a sign of cancer. The common offending problem is the ductal papilloma. So again, but we need to investigate for presence of papilloma. If a frank milk comes from both the breast spontaneously in a non-lactating woman, that is called prolactinoma, due to prolactinoma, which is excessive prolactin secretion. Not that usually it is copious, spontaneous, and come from both the breast, like as if the patient is breastfeeding. It doesn't come like a little bit on expression, but a lot of the times we come across these discharges and there is no role for checking prolactin measurements. The treatment, as I said, the papilloma of the milk duct is the main upper duct in a unilateral duct discharge. Ultrasound is diagnostic and a biopsy will prove it. Even though papilloma is a benign condition, it needs a surgical removal. The reason being, papilloma often harbors, it's not a pre-malignant, but it harbors in 5% of cases early cancer, what we call ductal carcinoma in situ. So this can be assessed only after complete removal, where full assessment of the papilloma will be helpful. Otherwise, a bilateral nipple discharge can be reassured once mammogram is done if it is normal. As I said, if no papilloma is identified and it is bilateral, all we need is reassurance. If the patient is very symptomatic, where there is a lot of discharge coming through and they want something to be done, then total removal of milk duct can be attempted, but normally it is not required. We should advise the patient to stop squeezing because that is what stimulates the discharge many times. So I'm just going to talk about screening for breast cancer. Just to a couple of slides on that. As in India, there is no structured screening program as in abroad, where the people are invited after a certain age, 40 or 50, depending on the country, to have a regular mammogram. So it is basically left to individuals and their physician to treat them to get the mammogram done. So there's a huge lack of awareness in women, and the women don't understand why screening should be done when they don't have any symptoms. So what I would suggest is it is precisely why they should do a mammogram. Breast cancer is the commonest cancer now in India. So asymptomatic people getting mammogram is what we call a screening. For a patient who has a symptom, it is diagnostic mammogram. So we have to improve the uptake for screening mammograms. Once the patient turns 40, they should be advised to have a mammogram. So that's what the next slide is about. Who should be screened? mammogram is the investigation of choice, and all women above the age of 40, they should have a mammogram. And there is no clear-cut evidence to say what is the frequency, but what I advise is yearly mammogram between 40 and 50. The reason being, there is a huge increase in breast cancer after the age of 40 in India. The bulk of the increase of cancer is not above the age of 50, but between the age of 30 and 50, especially after 40. So, ideally, and also usually the tumor occurs in the 40 to 50 age group is usually fast dividing. So, yearly mammogram seems to be reasonable. After 50, they should have a 2-yearly mammogram because, as I said, the incidence is still higher, but the risk of the incidence, the overall incidence in the last 25 years remains stable in the 50 age group. Usually, they are slow-growing tumors, so 2-yearly mammogram is ideal. So, overall, if patient doesn't want to have a mammogram on a yearly basis, at least 2-yearly mammogram should be advised for the age of 40. There are different techniques, digital mammograms, tomosynthesis, analog mammogram. I think as far as possible, we should advise digital mammogram to patients. And tomosynthesis is another special type, and contrast mammogram is again there are different way of doing advanced techniques. In conclusion, non-cancer breast symptoms are more common in women, and all breast symptoms should be investigated for most of the time reassurance. So most of the non-cancer conditions can with reassurance and the investigations, surgery won't be needed. If there are no symptoms, please do screening mammogram. Every woman you come across in their mother party, advise them screening mammogram. This is the only way to encourage them to have early detection, because the bulk of the cancer diagnosed in India is T3 and T4, which is if you look at abroad, it's more T1 and T2, even T what we call an in situ cancers in abroad. Here, very much it's a stage 3-4 disease. So that's what we are looking at, and by increasing the uptake of mammogram, I think we can certainly get the cancer diagnosed at an earlier stage, and the cure is possible in these conditions. Monthly self-examination, it's overrated, but something is better than nothing. So in that sense, the patient should be encouraged to have a self-examination, because you have to remember, once you feel a lump, it's already stage 1, at least minimum stage 1. So the best way to thing is, before it becomes a lump, we have to catch the cancer by mammogram. And always prefer biopsy over fine needle aspiration. I know fine needle aspiration has been in vogue for a long time, but I think biopsy is more diagnostic and also needs more information for treatment. A lot of the times patients come with FNAC. Unfortunately, they have to undergo biopsy one more time. So prefer the biopsy wherever possible. Seek advice when needed. Thank you.
Thank you, sir. Any questions for discussion? Any questions? Any questions from any of you? Please come up.
I'm Madhav.
Yeah. Hello, Madhav.
Fine. I just want to know the difference between fibroadenoma and fibroadenoma.
Fibroadenoma is a discrete lump where you have a clear lump, and it is categorized as a type of a benign tumor. Well, fibroadenosis is more of a diffuse changes in the breast. It's a benign breast changes, hormonal changes. So when the scan is done, ultrasound scan is done, there is no discrete lump. You see a lot of changes with cysts and lumps, and so it's called fibroadenosis. It's an older term. So it's benign breast changes would be an appropriate term in my opinion. Fibroadenoma is a discrete lump. So it's a benign lump again. Both are benign.
Thank you.
Thank you.
Actually, whenever we diagnose a fibroadenoma, generally we say above 40 or so, they say malignancy can occur in the lump. So, do we leave it, or what are the signs for changes malignancy to malignancy? Signs of malignancy in a fibroadenoma is
Fibroadenoma is not a pre-malignant condition. Actually, once diagnosed, we can leave it alone. When I say diagnosed means, I would prefer to confirm with a biopsy. So, based on the imaging alone, in a 40-year-old woman, if I say fibroadenoma and leave it alone, it would be a gross injustice. I think it could be a fibroadenoma very well, but at the same time, we have to be careful in that age group. So, I would do a biopsy. The biopsy confirms fibroadenoma, I would say leave it alone. It won't turn into malignancy. It's almost like a unknown. It's so extremely rare that we don't need to remove fibroadenoma for the sake of it. But what we cannot do is, based on the imaging, we just leave it as fibroadenoma. Say it is a fibroadenoma, don't worry. And so that is the thing we have to be careful about. And fibroadenoma, as I said, fibroadenoma is not a pre-malignant condition, so you cannot actually say whether it's turned into malignancy or not. So either it is a fibroadenoma or it's a cancer. Very rarely, I don't want to frighten everyone, very rarely, young women with family history of breast cancer, smooth, round, nice, lump defined as fibroadenoma in ultrasound scan can be malignant. Because the malignancy in a younger age group, like 30s and 35, they have a family history especially, they present as a smooth lump, and looking at it, it looks like a fibroadenoma. When you do a biopsy, it comes as cancer. So that's the main reason why above the age of 25, any lump biopsy is reported as fibroadenoma in ultrasound. So it all depends on what the confidence level. We have to have a clear discussion with the radiologist. Radiologists are quite convinced it's a fibroadenoma. Then yes, we can do a follow-up in younger women. But for any one woman above 40, certainly biopsy should be considered.
And regarding this nipple discharge in post-lactation, how long do we say it is normal? Because recently we had a case after stopping lactation, that after 6 months also she's got bilateral discharge. So you were mentioning about this prolactinoma. So what are the guidelines?
Normally 6 months is too long. Actually, usually it stops because physiology is so good. When the child stops suckling, within a week it dries up. Such a quickly it can happen. But if it continues beyond 6 months, we need to look at prolactin levels, whether the prolactin levels are high or not. If the prolactin levels are high, then certainly we can consider, giving tablets to suppress the lactation. That is a reasonable thing to do. Prolactinoma due to pituitary tumor, that is something comes in usually in the non-lactate women. So usually after lactation, it is not the prolactinoma, but it increased to prolactin secretion for some reason. It can be suppressed with a simple, suppression.
Any other questions?
The role of vitamin E. The role of vitamin E, sir.
In breast pain.
Yeah,
Next
yeah.
There is no clear evidence for vitamin E or evening primrose oil for breast pain. 50% of women do respond to breast pain with all these measures. But patients are happy if we write something for them actually. It gives a mental reassurance. That's the main thing. But there is no clear evidence it helps. No harm in giving. It's not like giving an antibiotic or anything. So there's no harm in giving. But what I would suggest is two things. One is always ask them to wear a supportive bra. Most women here, when you ask about the bra, they talk about the chest wall size. They never talk about cup size. So the measurement and wearing a correct size bra, a supportive bra, makes a huge difference in breast pain. And they will come up you will see the difference when they wear a proper bra. Second is, you can give this evening primrose oil, vitamin E, ask them to take for 6 weeks to 8 weeks. If it doesn't work in that time, usually it doesn't work. But most of the time, reassurance, and a lot of the times, if you look at if you take their history, they will come up with some stressful situation. Usually, they would have been normal, something like a relocation, marriage, or some domestic issues that precipitate the hormonal imbalance. Suddenly, the change. So the breast reacts to it. So breast pain comes. So once you reassure them, a lot of them they get better. Reassurance is all that we require.
So the role of ormiloxicin for pyrrolidine.
Roll up?
I know it's kind of
Sorry, ma'am. It's not clear.
Madam, sir, the role of ormiloxicin tablet.
Raloxifene.
Yeah.
It's a type of, it's like a tamoxifen. It can be given in severe pain for 3 months, not more than 3 months. We have to warn the patient that, they can develop DVT. That's one of the complications of, tamoxifen or raloxifene. The risk is low, but still there. Usually, in my practice, I have prescribed like a couple of times. Very, very rare. Unless patient really in a lot of pain with all the conservative measures failed, that the patient is in real pain, yes, you can give tamoxifen or raloxifene. More than raloxifene, tamoxifen is better in terms of pain. 20 milligram once a day for 3 months, not more than that, and it does work very well. But we want that, it has a side effect like DVT, and also, it is a hormonal manipulation. So, other than that, yes, certainly you can prescribe if pain is intangible.
Thank you. Thank you, sir. Thank you.
Thank you.
Good evening, sir. This is Arun.
Thank you.
Can I hear me, sir?
I can hear you.
Sir,
Deep in
in
the
your
well.
practice, what's the least age group you diagnose of fibroadenoma?
Fibroadenoma.
Yeah.
I have seen, in the 18, 19-year-old fibroadenoma, they are very common. Usually those lumps are not cancer.
What about 10 years, sir? 10 years?
10 years, no. It's usually breast, but it's not a fibroadenoma.
Yeah, actually, we came across a case, and I
Really?
operated the case on a 10-year-old child.
Oh my goodness. Why? You should not operate a 10-year-old child because it's a growing breast, but
The
That's
lump
not
size was almost 10 to 10 centimeters.
okay. So that was almost like a breast.
Yeah.
Sure. Yeah, so that is a different story. Yes, it's I have not come across one. Is it a giant fibroadenoma?
Yeah, it's a biopsy done, yeah.
Giant fibroadenoma.
Because I work as a professional insurance reaction.
Sure.
Yeah. Because last month we had a case, a similar case.
Very interesting.
10 years child. In the US,
Very interesting. I have not come across the youngest age I came across was 17 or 18. But cancer I have come across the youngest age is 23.
case 10 years we operated.
Okay. That's interesting. Thank you.
Any more questions? Okay. Thank you very much, sir, for this very elaborate and very nice presentation about benign breast disease. And we're very happy and honored to have you here with us today for our CME. And we have many carry-home messages useful for our clinical practice. And thank you very much, sir. Thank you once again.
Thank you for having me, madam. Thank you.